session for Purposeful Aging this year. And we are very, very lucky to have Dr. Lydia Mungherera as our guest speaker. We do run these sessions every last Saturday of the month at 10 o'clock. And we welcome suggestions, ideas of what you would like to be covered, for us to cover. Participants are mainly two categories: caregivers, and this is a varied group of people. They are not necessarily medical, but they could also be medical people who look after or who help the older adults in their homes. So the sessions are mainly in a language which all of us can understand and all of us who are not medical can be comfortable with. And then the other group is the older adults themselves, anybody above 60 years, 50 years plus, up to 100 and so. So this Saturday, we are very lucky to have a topic which has concerned us and the world since 1980. And that topic is to do with HIV/AIDS, but particularly concerning the HIV/AIDS as seen in the older adults. I understand there've been so many changes in terminology, and you might have to excuse me for being stuck in the old terminology. But today we have Dr. Lydia Mungherera. I think I'll just go straight on to introduce her. She's a medical doctor by profession. She has served as a senior medical officer, health educator in government hospitals in Uganda and South Africa. She has had a wide exposure in medical policy making, working with people who are living with HIV/AIDS, and she has worked a long time in with the very people who are living with HIV/AIDS. She has co-founded a number of grassroots initiatives. She's passionate about women. She's had a big stake in policy making, especially in that line of HIV/AIDS. She has worked with Our Good Tasso in Uganda, and she was engaged in the development of ART curriculum for training the community health workers. Most importantly, Lydia is the first medical doctor in the sub-Saharan Africa who openly declared her HIV status. Dr. Lydia dedicates her life to reaching out to people living with HIV/AIDS, to empower them with the knowledge and skills to live healthy and productive lives. She has used her knowledge and advocacy skills to enhance HIV prevention and reduce stigma among people living with HIV. Obviously, Lydia graduated from Makerere University with MBCHB And over the years, she has obtained several certificates in strategic planning, advocacy, and building skills, policy making, and leadership building. Lydia is very, very passionate. She's a very good communicator. And I think Purposeful Aging is blessed this morning to have a person of that caliber to talk to us for the next 30 minutes. Next 1.5 hours. After her talk, we shall have the usual question and answer session, and we should be able to close after 1.5 hours. I think without much ado, I would like to invite Lydia to come on and take it on, please, Lydia.
Thank you so much. Thank you so much, everybody, for coming onto this talk. And I really want to especially welcome the network of women living with HIV as far as Ghana. I think Elsie is here from Ghana. These are my sisters. We have lived with HIV for many years with them. I see Florence, I see Elsie coming in from the Pan-African Positive Women's Coalition, which I was also a founding member. This topic is very passionate to me. In 1997, just for a few minutes, I have to tell you where I'm coming from. From 1997, in 1997, I tested HIV positive. I was living in a country outside Uganda, in South Africa, where I was working. And my husband died in 1992 from disseminated tuberculosis. By then, in South Africa, we couldn't talk about HIV. He went through a difficult time because he had TB, and we suspected even going for testing was a taboo for us, me and him, and we had just got married. Like when we arrived in South Africa, we had only been married for 1 year, and this was about down the road 6 years. And we were scared, totally scared. Now, you know, you're a medical doctor, you're working in the wards, your husband is already very sick. You think definitely, you know, you probably are also infected with HIV. So in 1992, he failed on treatment. You know, ARVs had not come into South Africa. He was on TB treatment, and then he had gone down to Pretoria to specialize in psychiatry, and that's where he passed on. Very tragic and traumatic time for me. I had 2 small children. We brought his body back to Uganda, buried him. I went back and I was healthy. That's 1992. 1996, I started falling sick. By 1997, I was very sick. I was actually up on my deathbed. My late sister, who was a medical doctor, Dr. Lydia Mungherera, they decided with the family that she comes and brings me back home. A lot of stigma. I underwent a lot of stigma because people knew I had HIV, and there was blatant stigma even in the hospital where I was admitted. I was just being given sedatives to sleep, and it was terrible. I reached a point of HIV dementia. I didn't even know how I got back to Uganda. And I was definitely, if anyone saw me or looked at me at that time, they knew I was dying in the next 1 or 2 days. And by the time I got back to Uganda, I had a CD4 count of 1. People can't believe that I had a CD4 count of 1 when I got back to Uganda. And I was, my sister had been through the Vancouver conference discussing ARVs, and said, you know, Lydia, I think we can do it. We can start. And she was talking to herself, talking to family, saying that, you know, so through the Joint Clinical Research Center, where drugs were available, ARVs available, but very expensive, not affordable. My parents and family put money together and they started me on antiretroviral drugs. It was a slow start because I had tuberculosis. I still had HIV. All the things, my CD4 count was just 1 and rising. And by that time, no one knew, no one could suspect, could even think that I can live longer than just 1 or 2 weeks. But you know, the mercy of God is there. God, family support, ARVs, started working slowly because I was on TB treatment. I finished TB treatment and slowly, I came back to life. And actually, I'm calling it my journey back to life. If I was to write a story, I would call it my journey back to life. So I started living again. And I joined the National Guidance Empowerment Network of people living with HIV. Major Varamila had started a network. I joined a group of activists, and together with them, we started talking about living again. And by spreading our testimonies, going around networking, joining together, the drugs were very difficult to get. They were very, very difficult to get because, you know, sometimes friends would bring them from outside. My family, my mother sold off even a piece of her land to be able to get the drugs. And then, you know, so this is how I started my life. Really difficult, but a very, very, I started coming back to life. And when I came back to life, was my old Lydia again, really determined to live. I said, I'm not going to die. I had 2 children. There was even a time when I had just come back when I didn't know I had children. So my cousin sister, Loy, took my 2 children and decided to live with them and said, you know, she's not in a stage of even knowing she has children. But later on, I got to remember her children. My mother, my late mother, and my late sister were the warriors in my life. Really, my mother wasn't a doctor, but she fought. She fought this battle with me. And my late sister, Dr. Margaret Mungherera, some of you know her, she passed on. And those were the people who actually fought and fought. And, you know, so when I joined the network and we're moving around, trying to look for people who are living with HIV/AIDS, trying to build coping skills, trying to make people realize that, you know, you can live this life. Unfortunately, no drugs by then. So in 1999, I joined TASO. And Dr. Sophie Mukasa was, my sister said, you know, you can go there, tell your story, encourage other people to live. So I joined TASO, the AIDS support organization, and I started, you know, working as a medical doctor part-time in TASO. And then, you know, with TASO, I grew in many capacities. Actually, I may be the only staff who was moved from different job descriptions, actually without a job description, maybe from job description to job description. From TASO, I moved on to being an advocate. I moved on to being a, you know, treatment supporter. I moved on to being a trainer. And I did so many things in TASO. And in that meantime, I had also joined International Community of Women Living with HIV. I was actually now being invited internationally, globally, to go and discuss prevention, you know, again, guidelines with UNAIDS in Geneva. So I started moving to Geneva. By then, by the way, we had started what we call the International Treatment Preparedness Coalition. It was Millie Katana who said, you know, we're going down to Cape Town, and we met many other people living with HIV from all over the world, and we started the ITPC, International Treatment Preparedness Coalition. And then we founded PATAM, Pan-African Treatment Access Movement. From then on, I joined the global world in trying to look for, you know, treatment. So WHO caught on to me and started inviting me to discuss treat ARVs. How do we start giving out ARVs in resource poor countries? And I joined those high-level professors. I didn't know much about, you know, all these ARVs and what. So I didn't know the chemistry, how we're going to, you know, there was a lot of science. And they used to invite me to Geneva, sometimes to Paris, and we developed guidelines. And I came back. And then TASO was advertising for team leader for antiretroviral therapy. And I went into that interview for that particular post, and I came out of the interview with a new post created for me. So they said, you know, with all this that you have been doing networking, we are going to give you a post which you have now described for us. And I became the advocacy officer for the antiretroviral therapy program in Tasso. In 2004, drugs came in. So drugs came in to Uganda. There were no free drugs. And by that time, I had also, because I had joined the Uganda business, I had left Tasso briefly for 3 years, and we formed Uganda Cares. You know, Uganda Cares was the first actually grassroots community-based organization. At that time, it became a big NGO, which started giving out free drugs. We went to Masaka, we got a clinic, a room, we brought it into a clinic in one of the old buildings, and we started Uganda Cares. So by the time I joined Tasso, we had given some treatments with the partnership of AIDS Healthcare Foundation and given a few people drugs. So Tasso started bringing drugs. As soon as Tasso started, the government gave drugs. So this is my journey in getting treatment for people. And Tasso, we started giving out treatment to people. Then the Ministry of Health decided to start a policy making, they said, let's start ARV policy. So the moment I came in, they said, Lydia, you're here. What do you want to do? I said, I want a community and advocacy subcommittee. Because it's not about just giving drugs, about talking to people on the ground about treatment. And that's when I started chairing the advocacy subcommittee for treatment in the National ART Policy Committee. And that was like my very first work with the Ministry of Health. From then on, I've done so many other things. I chair the community technical working group in the Ministry of Health. I then joined the Health Policy Advisory Committee. Global Fund was coming. I joined the country coordinating mechanism. And I was actually, I think I must have been the longest serving officer on the CCM, the country coordinating mechanism for Global Fund. But remember that we were the activists who actually caused this Global Fund to happen. We were the people who said, you know, there must be a fund. And with Kofi Annan, that time at the UN, he really saw that, you know, we needed this fund to fight TB, HIV, and malaria. And by then, we were moving around all over the world. When there was a conference, they invite us. We were the very strong activists. Activism to see people living with HIV alive on antiretroviral drugs all over the world. And then, of course, my passion with women. We all know the vulnerability of women with HIV. I then, you know, joined other activists. I co-founded with a group of people, the Athena Network, looking at sexual reproductive health and rights for women. I was part of so many movements. And there was a time then we started the Pan-African, we said, let's start a movement for women, just for women living with HIV in Africa. And that's when we got together with people like Elsie Aye, who's on the group. Elsie, thank you so much. She's one of my co-founders of the Pan-African Positive Women's Coalition. Then that was, and she's from West Africa. And we got people from Africa and we started this movement. Because we said, you know, there is so much dealing up that the outside world is doing. But we in Africa, we know our issues. We know the African woman in my backyard. We know what she undergoes. And that's when I formed Mama's Club. And I decided to form a network of mothers living with HIV. And I was telling Tasso, when I left Tasso, I then formed Mama's Club to become a full-fledged NGO, building networks of mothers living with HIV. Because most of the mothers, most of them were single women, or they had been chased out of their homes, or they were widows, and they had these small babies. And we didn't even have money. By the way, I'll be honest with you, we started this thing with a group of friends, including many others. I had Margaret Muganwa, professor. I had Professor Mirembe, she was our patron. I had Mama Angelina Wapakablo, a group of women getting together, said, let's start this organization within Tasso. But Tasso really supported us as a network before we got out on our own. After that, I joined, of course, the Health Policy Advisory Committee on Ministry of Health advising, and then so many other things. I mean, I can't talk my whole CV, it's so big. It's so much that I've done, but I haven't done it alone. I've been supported by a group of wonderful, wonderful activists, people living with HIV, women living with HIV. I see Florence there. She's the head of that. She's the coordinator for NACOLA, because NACOLA was our National Community of Women Living with HIV. And then later on, recently, we formed Women at 40. Not 40 years old, but 40 years of women fighting this pandemic. And we now have a strong network of women living with HIV, and we call ourselves Women at 40. And then that's when I became I was appointed on the board of the Uganda Commission as a commissioner, but I was elected actually because the Uganda Commission board now became had self-coordinating entities, and they allowed the civil society movement to elect their own people, network of people living with HIV as young people. And I got on and I became a commissioner representing civil society on the Uganda Commission board as a commissioner. And I cannot tell you, it's a long history of pain, history of I say I would call it fear, pain, suffering, happiness, happy to serve, and wonderful, wonderful memories. And that's how we are. Now, recently it was found out that by the global UNAIDS discovered that over 50% of people are actually over 50 years old living with this virus. So, we now have to look at these people. We've been on treatment for so many years. We are over 50 years. I'm 65. And what is it that's actually disturbing or killing people of our age? It's not only HIV. It is actually non-communicable diseases. Diseases like diabetes, high blood pressure, heart disease. So now we've got to look at aging with HIV. This is the area which is most important right now, because many of us are at that age over 50, and things which are disturbing us now, there's mental health. Very, 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 very strong on the agenda is mental health. There is, there are many things that have happened in our lives. We have high blood pressure, we have diabetes, we have heart disease. So now we've got to say that we have to go beyond the issue of HIV, and knowing very well that tuberculosis is like a twin sister to HIV, because most of the people living with HIV die of TB. So TB is still there. There's malaria and other things which kill people living with HIV. And of course, we know the pandemics, which come in, like the last recent coronavirus. I think I'll stop there so that we can move on, maybe. There's so much to talk about. Thank you, Christine.
Thank you so much, Lydia. This background is very, very important, very, very moving. And I think many of us have never imagined that things can be this bad. It's very, very good that you brought out the people who cared for you during that time, your mom, your sister, and I think many other people in Uganda, the community, which received you and looked after you. At present, to many of people living with HIV/AIDS, this is unimaginable that you fought, you've walked this journey. I'm happy that you've shared it with us. And it's going to stimulate a lot of questions and comments from our attendant this morning. Thank you so much also for inviting the fellow fighters, let me call them fighters, who are here with us. You're most welcome. You mentioned Florence and others. Thank you, Lydia, for this.
I can see them here. Wow. I can see Proscovia is fighting. She's from Toro district, also from Women Living with HIV. I don't know if I can finish all of you, but they are my network of people who are actually fighting with me, my sisters, my support system. Proscovia, Namakula, they're all here. Network of women living with HIV. I don't know what I would have done without all these people. They're really there. They've been there for me. They're part of my life. And I think we fought this battle together.
Thank you so much. Originally, we had a few questions set out for you to answer.
Oh, I see.
I'm
Also,
not
sorry, I just feel so excited to see Esther's an ambassador from South Africa. She was there when I was very sick. Florence Baingana, she's my sister. They're all here. So
I want to
Barbara. If you are Barbara. Yeah, Barbara too. Okay. Move. We can move on now.
You want us to move on with the questions, or we can invite one or two of the people mentioned to put in a word or two? I'm sorry, this is abrupt. We didn't prepare you for this, but I think there are areas where, you're here and you've got the experience, and it's a rich experience. Our caregivers and people living with AIDS who are on this meeting this morning can actually are going to benefit a lot. So Proscovia, Florence, do you want to say a word before we continue? Or any other person on the forum?
Yes, I want to say something.
Yes, Florence.
Hello. Yes, good morning, ladies. Good morning, ladies and gentlemen.
Good morning. Good morning.
Thank you, Doctor, for that elaborate sharing. It is really touching and it is encouraging. But before we go far, I wanted some clarification on those two words: people living with HIV/AIDS. Can we find a way of separating the two for clarity?
Yes, I was going to say that, but we now say people living with HIV. The word AIDS doesn't come in at all, because people living with HIV don't have AIDS until they get the AIDS syndrome. And most of us who are here are living with HIV and not AIDS. That is a clarification. Thank you. I think Pros has made it very clear there.
Yeah, yes, that was what I wanted to be clarified. Thank you very much.
Okay.
Thank you, Doctor. Thank you, Dr. Lydia. This is Proscovia, you're from Tororo. Indeed, you have really done great work. You have shared greatly about most of us, especially with the women. Now that we have realized that God has had mercy for us, that we are living with HIV, and most of us are 50 years old and above. And you've said women at 40. I think I would like to say we get stronger. Sorry, excuse me. Become strong on that. There are very many other women, especially down in the rural communities. Dr. Lydia, I remember our friends who used to be drama members. Now they are really gray-haired and quite old. When you meet a friend, you hug and endlessly hug. And after that, you go. But your heart remains looking behind, looking back at her. She's moving away. You're also moving away. We don't have where to meet. Sometimes when you meet one far out there at an outreach, you sit down and hug each other and cry and fall down and all that. By the time you're leaving, your heart hangs around wanting to continue talking and talking. Like, to feel so nice, to feel so sweet to hear you, Doctor, the way you're expressing. I am following and I'm seeing all these things unfold because surely I've been following you. I've been following you. It's in some countries we've met out there in other continents. I have followed. It just feels so sweet. If we could have an opportunity to have such friends down in the rural communities, in the village, they are lonely in their homes. What can we do? What can we do? Meeting is one great thing that I think can revive all of us and we appreciate so-and-so is still alive, so-and-so died, so-and-so is, no, the children are here, the grandchildren, I now have grandchildren. That talk, the way you're doing it right now, it makes us feel so great. Is there a way we can plan that? Graying mothers in Uganda, graying mothers in a small community in Tororo, what can we do?
Thank you. Thank you so much, Pros. Christine, you are still
Thank you so
moderating.
much, Proscovia. Yes, Lydia, and if we don't have any questions, we would like you to go through the questions we had asked you to cover.
This is Proscovia. I have my hand up.
Yes,
The same
Proscovia.
There are two Proscovias in the group.
And this is Proscovia Namakula from Chiso.
Namakula, Proscovia, please go ahead.
Thank you for organizing this. I want to thank Dr. Lydia for this good advocacy. I think, Dr. Lydia, I would want to say that your advocacy has made some of us who are introverts, I must say me, I'm an introvert, but the outspoken people like Lydia have made us survive. Because when Dr. Lydia shares her experience, I think I was also within that time. But
Yes.
me being an introvert and being in my circle as a university lecturer, how would I have HIV? But it was where some advocates, the Flavias of this world, who pulled me out and said, come to Nakola. And I would drive to Nakola and I would feel safe to interact with women living with HIV. It's not like I didn't have money. I had the money. I could sustain myself. I had everything, but I needed that psychosocial support from friends. And it's what made me survive up to today. But what I realized, Doctor, that this kind of psychosocial support has died with the era or in the event of medicine. And people no longer meet, as Prosi has said. And I feel sorry for our young people. They sort of live in their own world. They don't have these meeting psychosocial supports that we had in our times that made us survive and that made us keep on hoping until we finally got to the medicine. We kept each other without the medicine until finally we got to ARVs. So, Doctor, what can we do to really bring back that kind of psychosocial support and bring up this kind of advocacy you guys had? You know, we are different. Some people will talk and others will keep quiet there. And me, the best I can do is to do the paperwork. I might not be as loud as Dr. Lydia, but a combination can make us move on. So, Doctor, I'm asking, how can we bring this back so that our young people there who are silently dying within their, of course, with different challenges also come together and support each other? Thank you very much, Dr. Lydia. Once again, over to you, moderator.
Moderator, I'd like to say something.
This is Lydia's phone. I see Lydia's phone. Is that?
Yes, I am. I also happen to be Lydia.
Please go ahead.
My name is Lydia Proscovia Ocheng Obo, and I was classmates with Lydia from S1. We parted, of course, when I went to do medicine, and I went to do law at Makerere. And I thought it would be fair for us to say something as Lydia's classmates for what Lydia has done for Uganda and indeed the whole world. Lydia has not only helped people who are living with HIV, but has also helped those of us who have got relatives and friends who are living with HIV, how to deal with them, how to be compassionate and to accept them as normal people. Because you remember at one time there was a lot of stigma around this HIV, and I think Lydia and those of you who have worked with her have made this to be a normal disease like any other. And for that, I think Lydia deserves an accolade and thanks, and that's why I decided to speak up because we have got relatives who are living with HIV. And because of Lydia, we have been able to help them, we have been able to comfort them and to support them, because we saw that our own, because Lydia is my sister, has been able to overcome this. And whenever we see Lydia on TV, Lydia presenting programs, Lydia traversing the world to drum up support for this effort, we feel proud as her classmates, as her sisters. And I thought I should, first of all, log in and speak on behalf of Lydia. Lydia, thank you very, very much. I have a sister who's living with HIV, and I'll share with you, but your strength has been my strength, and we have supported her. She's now 60 years plus, and she's very, very positive. She lives very positively, and she's preaching the word of God, and because of your strength, you gave me strength to support her, and I'm very proud of you, and very proud of all of you ladies who have walked this path with Lydia and supported her. May God bless you, and thank you very much for this occasion to share.
Thank
Thank you very much, Lydia, the lawyer this time. Now, Lydia, Dr. Lydia.
Yes, Christine.
We've got several comments in the chat, and you are aware of the questions we had put to you.
Yeah.
Would you like, and from what has happened now, would you like to continue? Because I know you will cover the questions, but in your own,
Yes. I would like to, yes, Christine, can I go ahead? One of the things
please do.
One of the things that somebody talked about, for example, how do we bring back this movement that we started in the 1990s? How do we bring it back? And I think I can only answer for Proskovia Namakula that we ourselves must be the living example. Remember that how we started by giving ourselves the face of the epidemic, the pandemic of HIV. We had the face, we had the words, we had the testimonies. We talked about our lives, we talked about this disease. That has faded with the coming of antiretroviral drugs. People are now living normal lives. So it wasn't as if it was in that time. And I think coming together in that big group of what we call the women at 40, women getting together, we even have very young women. They've joined us in this movement. They are with us in the movement. We are mentoring them. We are telling them what to do. But the situations change in life. Right now, the treatment on antiretroviral lives, drugs, living their normal lives, going to work, living it, but they're not, their lives are normal. I would say normal, but not normal. I mean, I take myself as an example. I feel I'm living a normal life, but it's not very normal. I know very well that I have to take these drugs for the rest of my life. I know very well that as I'm growing older, there are other things coming in. My changes. I mean, as we grow older, we develop different changes in our systems, changing in our physical anatomy. We change. And you know that as part of the questions, some of the questions had something about what are the signs, for example. I mean, I have, for example, I have high blood pressure now. I didn't have high blood pressure before. Other people have developed secondary, what we call type 2 diabetes. Others have developed heart disease, just the way of life that we've grown older. And then the other thing is, of course, as we grow older, our children have moved away from us. We don't have them with us living in our homes. So that brings a little sense of loneliness. And somebody talked about loneliness. Many people, as they grow older, they become more lonely. And, a lot of things have gone through in their lives that things have changed, and it affects our mental status. So things like mental health come in, where, there's people have got into stages of depression now as they grow older. And we have to take note of these things. There are not so many And I'll be honest, because I'm always honest about what goes on around me. There are not so many health workers who really can handle the elderly that well. Like, in some countries, there's the study of geriatrics, which is studying older people. And people, the people know how to care for older people. Now, in this country, in our country, Uganda, we have a few people who deal with older people. But, as we grow older, the attitudes of health workers towards elderly people is not always good. And this is me being honest. So we need that special care for older people, because older people suffer from different conditions. They talk differently. Their attitude has to change. So these are the things that are confronting us right now. The health system that we have, does it deal with elderly people in the way that it should? Do we feel comfortable? Do I feel comfortable talking about my sexual reproductive health issues as an older person? How am I viewed? Sometimes people look at you and say, at this age, is she having sex? And this is being open, because people say, is this woman having a boyfriend? Is she having sex? Why does she come with this condition, a discharge, or itchy vagina, or whatever? People must know that even the vaginal system, the reproductive system of elderly people change. And we've got to be very conscious of many things. This is the age where even cancers crop in. We can have cancers of the bone. We must start noticing even abnormal discharges coming from our vagina as older women. And this is why so many cancers are missed. We must start saying that as we grow older, who's going to examine me? And when they examine me, what do they think about me? So all these things of attitudes of health workers seeing me as a person I'm too old to start talking about sexual sickness. I'm too old to talk about, the changes that have happened in my anatomy, my sexual anatomy. And these are the things which cause people with elderly people sometimes to feel stigmatized themselves, and feel stigmatized in health centers. So we really need to have people who understand us as people who have grown older. We need people to understand us. And then the other thing is this loneliness I'm talking about, and Proscopia has talked about it. Where is that time when we used to meet as women, as people living with HIV, hug each other, sit down in networks, and that time has gone. We're not doing it anymore. And this is one of the issues that affect us. If I wasn't so busy doing so many different things as Lydia, my children are living very far away. They're in another country. And if I wasn't so busy doing all the work that I'm doing, maybe there would be a sense of, not really depression. It can turn into depression, a sense of loneliness, a sense of saying I'm no longer useful in the society that I live in, if I wasn't that kind of a person. So we've got to be aware that as we grow older, we are distanced ourselves away from many of our close associates. And if I wasn't having all these networks, my sisters from Gayaza, where I went to school, how would I be? So having an active mind, an active body. So we've got to talk about, elderly people being active, maybe with the support of other people, not to just let them stay in the home, taking these drugs where there may be so many other side effects which come in, and there are side effects which come in. We don't know the side effects of these drugs we're taking for many years. We don't know what's coming in future. I don't know. Many people have got bone changes. Many people have got, changes in their structure. Some people are even sitting on wheelchairs because of these antiretroviral drugs. And we've got to think about this, that what are we doing for these people? So for me, I believe a community system, health system, needs to work for us as people living with HIV. We need to have community health workers. We need to have more counselors. We don't have enough counselors in Uganda, for example. We don't have them. We need to have people who can build these networks of elderly people living with HIV and also thinking about what does this person do when she's alone in her home, when she may have lost her husband, she may have lost her friends are going away. She may not be able to make food for herself. So those days that TASO taught home-based care, going around visiting people in their homes, this has got to work for elderly people too. And then, of course, she may not even be able to get up to go and collect her treatment. So this kind of community-based outreach work, peer-to-peer support, that's what we called it, the buddy system. Who's my buddy who lives with HIV who can come and sit with me and talk with me? That's the beginning of networking. And this affects our mental health. And many of us can't diagnose mental health. When a person stops eating food, we think there's something, it is something else pathological. It is part of the beginning of depression. The cognitive function in our brains, it changes. There are these debilitating diseases now. There's Alzheimer coming in. These degenerative diseases come in. Who's going to be around to help us? So the health system has to be able to have people who go out, community outreaches, who go out and look for these people. This is what I'm talking about. And I think the WHO right now, World Health Organization, has come up with guidelines for working with elderly. There's a UN decade of aging. And I think there are many people doing so many things, but within ourselves, as Prosy was saying, within ourselves, with our rural women, what are we doing? We need to revive those kind of get-togethers, those kind of networking, those kind of togetherness, that kind of, we are trying our level best to say, let's go out in the community and look for elderly people who live with the disease. Get them, link them to the health facility, but also get the facility to be friendly towards them. I don't know if I've answered or if I've talked too much and there are other people who want to say something. I'm not sure, Christine. You can let me know.
Lydia, you haven't talked too much. We are benefiting from each and every word you're saying. And I think you've covered well many of the questions we had put to you. But at this juncture, I would like to invite Dr. Philippa to draw your attention to the chat box. And from there, we'll stimulate more conversation.
Maggie,
Dr. Philippa,
Right. I think there's been a hand up from Maggie Chigozi. If you could go first, and then I'll read the questions from the chat.
Thank you very much. I am oh my God, my hair looks terrible. I think I'd better take the video off. Hi, Lydia. Hi, Christine. Hi, all of you. I am so privileged to be sitting on here and listening to you, Lydia. I call her my bully. Lydia can make me do anything. If it's a good cause, she will go after me with everything, and I will sit in these meetings and will go and advocate for women's rights, for men, even men's rights we are advocating. Yes. So Lydia, thank you so much for taking leadership in the voice of the people. That's what Lydia does. And to have stood up to that stigma, and I am just lost in admiration, Lydia. I thank you for the work you do, and please don't stop. Obviously, you're not lonely. You can call all of us anytime to bully us into any activity. So that is the Lydia that I know, and I am so proud of her. Thank you.
Okay.
Thank you very much for that. And thank you, Dr. Lydia, for your wonderful testimony. Indeed, it's a journey that we have learned a lot from. And I just wish it could be out there for, like someone mentioned earlier, for the younger people to see and have the zeal to live positively and push on. So I'll go to the questions. We have a few questions in the chat and a lot of appreciation for your testimony, but I'll just move to the questions. There's one from Dorothy. She was interested in She said how it's so touching, a testimony. Doctor, thanks for the advocacy work and commitment from CD41. Now I would love to know the viral load currently and what strategies you have put in as an individual to continuously take your ARVs without forgetting. A related question from Shaban. He also thanked you for your sharing your experience and asked how easy has it been for you to take your medications and how many regimens have you been through? Yes, maybe you could answer those and we'll get another set. Those are around how to be adherent to treatment and the regimens you have been on. Over to you, Lydia.
I must say, and because you know me, always telling the truth. At the beginning, it was hard, and at the beginning, it was very difficult to say. With my busy lifestyle, actually, people tell me, Lydia, you're so busy. How do you manage to do all this and take your medication? I just was very happy that, that when I was very, very sick, I was groomed into taking medication on time. I mean, I had those like my late sister, Margaret. They had, at the time when couldn't even walk, I was in bed with them. There was a book. And, my auntie, it was my auntie, Auntie Joy, and others were looking after me. They had a book and they had written how. And my father, by the way, was part of the system as my late father. There was family, there making sure that at this time you take this drug, at this time you take this drug. There was that kind of grooming at the very beginning when I was very, very sick. And I think that stuck to me. And that's how it remained in my mind. In the morning, I must take this. But that's the time, remember, we were taking medicine like 3 times a day. Now the drug regime has been easier. There's twice a day, and there's even once a day now. So that was part of it. So what happened is that we trained ourselves, and then later on we got the pill boxes, which helped us say that, put a pill box next to you. When you wake up in the morning, you must take this drug at this time and then this drug at this time. If you are traveling, always move with something in your handbag so that in case you are stuck somewhere and it's time for taking medication, take this drug. But, it's in our conscious that these are the drugs that have kept us alive. I mean, when you think about it and you say, I want to live, then I must take these ARVs and I must take them on time. And then the other thing is that this is what we are teaching people in the community. We're teaching them every time. That's been part of our lives for all these years. Take your medicine on time. You must take your drugs. So this has been our voice and our treatment literacy messages from many years ago. So that has helped me with adherence at all times. This is what I can say about adherence. The burden of I think there's somebody asked about the different. These are not the medicine that I took at the beginning. Remember that at the time when I started taking treatment was very difficult. There was no free medication in Uganda. My parents tried so much, my great and family, and the rest of the family, they were there for me, putting money together, my mother selling of her things to do what, and that was difficult. So there were times when I couldn't take treatment. I didn't have treatment. So because of that, I became resistant to my first regime of treatment. And then I moved on to my second regime of treatment, which was another regime. And then I had an opportunity to travel outside the country. I guess it was for a conference. I did my drug resistant test, and I found out I was resistant to one of the drugs. So that whole regime again had to change. So I moved on to my third regime. So this is like my so when I moved on to my third regime, I think I had side effects. I had the side effects. I had pancreatitis at that one time, my pancreas, and those kind of side effects. And then I moved finally on to this fourth regime. So this is like my fourth regime of drugs that I'm on. Answering Dr. Shaban. First time, lack of and difficult to get the drugs, so I didn't take them all the time. Second time, some side effect. And then this is like my fourth regime where I'm taking Aluvia. and xenophobia. And actually, to be honest, I'm supposed to have been asked so many times to change onto the latest DTG regime. And I've just said to myself, no, I've just totally resisted to move from the regime I'm on, where I have no side effects, which I'm used to taking morning and evening. But now there's a regime where you can take one drug a day. It's available. But I'm on my 4th regime. Yeah. Those were the 2 questions.
Yes.
Philippa, so far.
Yes.
I don't
Let
know
me
whether
give
I've
a
answered them
chance to
correctly.
Yes, you have. I'll give a chance to Florence Baingana to voice over before I go to another set of questions. Florence, you can unmute and speak.
Thank you. Thank you very much for organizing this session. I'm Florence Baingana. I'm a psychiatrist as well as a public health specialist. And as Lydia mentioned, I'm also a sister to Lydia. We were one of those people who were with her when she came back from South Africa. And I think the difference between us in Uganda and many countries I have been to, because I've worked in like the region with oversight for 47 countries, and I can say confidently that the difference we have in Uganda compared to other countries is that willingness to speak out, which I think has been spearled by people like Lydia. People speaking out about being HIV positive and the stigma and the discrimination, if you speak out, then you disempower those who would want to whisper about it and keep it hidden and covered up and this and that. So we have been able to move forward because of that. There are countries where they have the ability to provide medication to a single person for a whole year. You have a visit once a year. In Africa here, you have a visit once a year, but you go to that country and you find that they are not talking about it. It is all hidden, it is covered up, and so the people living with HIV are not actually taking their medicine or not going into the clinics to get the follow-ups, and even just that sense of feeling shame within yourself because the world has put that shame on you makes it very difficult to live. So I want to congratulate Lydia very, very much, and all her colleagues and peers who have done so much to dispel this stigma and discrimination. I also mentioned that I am a psychiatrist and public health specialist, and I'm sure you all had the issue of mental health coming up very frequently for people living with HIV, but especially I think as they get older, as we all get older, but as they get older and having lived with this illness, I think the question I have for Lydia, and maybe anybody else here who may want to share, is when you are younger and you're living with HIV, let's say, it is easier. I imagine it is easier for you to live within your family, with your children. Maybe you've shared with your partner, with your siblings, maybe your friends, no? And that side is easy. But at what point do you disclose to your children, and how did you do that? Because I know that some of the older people who are living with HIV are now, that reversal where now we become dependent on the children. For the children, for those who are older now, and maybe you have to go to the child to get your money to go to a clinic for a checkup or transport to go to the clinic, which is the case for some people. Some of us are very independent, but for some people, you may need to go to a child and say, well, I need to go to the clinic, and the child will say, for what now? So how is it? How do you manage that? How do you balance that disclosing to adult children if you have not disclosed to them when they were younger? So if you could talk about that a little bit. Yeah, I think it's something that people may want to hear about. Thank you very much.
Yeah. Christine, should I answer that one?
Yes, please go
Yes,
ahead.
please.
Disclosure. No, I
Answer
think
it.
one of the most difficult things with people living with us as people living with HIV is disclosure. It's very difficult. I took some time to disclose to my children. It was very traumatic because I didn't disclose to them, and then my daughter found my treatment somewhere, my tablets. Of course, she had to find them. She found them because you can't hide treatment like that. And it was very traumatic for her because then she said, "Why didn't you tell me?" And that time it was really sad because I just wish I had disclosed because I was sick. When I was sick, my children were very young. So I thought, oh, these children are too young. When I recovered, I thought, oh, let me plan to disclose to them. I planned to disclose to them. And I took time. I think I really advise that we need to disclose to our children early enough and walk this journey together. It's part of our healing. It's part of our mental well-being. It's part of knowing that your children know what you're suffering from. It's part of knowing that, this is my closest family. I must really disclose to them, and then we walk this journey together. And Nakola came up with what they call the memory book. Because remember those days there was no treatment. So the memory project, where the women sat with their children, they drew up that memory book together, how we've lived our life together. And I think this was one of the things which was very, 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 very useful to these women. It gave them a feeling as if I have my children on board with me. And I think the memory project was one of the best. I think it's even spread all over the world. But I think disclosing to your children as early as possible, not only your children, your family, who you live with, because people have hidden this disease, and sad for the young people. They say, I can't tell my mother, I can't tell my father, I can't tell. I'll probably be chased out of the home, and it's really traumatic. And it's not good. It's not right. So disclosure is part of our healing as people living with HIV. Disclosing to your partner, disclosing to your children, so that you live this life together and explaining to them about it. Because your children, when they're young, they don't understand. Most of the children, they know very well that only people, when they're young, they know that people having HIV are these promiscuous people. It's a wrong impression. So it's good to know that, I suffer from this disease, because they may ask why. And then you have to explain to them that's a sickness like any other that I got. You need to explain. So, Florence, thank you for bringing this up. Disclosure is part of our healing. And for me, as Lydia, disclosure was part of my healing. If I hadn't disclosed, if I felt that, let me hide this, it's part of self-stigma, it's part of self-blame. Why did I get this disease? And many people used to come to me in Tasso when I was sitting there, and we talk about their lives. And those who have not disclosed, you could see the pain, the fear. How am I going to tell my children? How am I going to tell my partner? How will I tell my parents? Disclosure is part of it. So the earlier we disclose to our children, our family, the better and the faster your healing. Thank you.
Right. I'll follow on from your last point, Dr. Lydia, and ask you to maybe give us some tips for older adults or even adults in general on how to deal with the stigma, the self-stigma or stigma from community health workers. What tips would you give people to go about that?
Yeah, when I first found out I was HIV, I was in a country which was full of stigma. HIV became like the worst disease in Southern Africa at that time, later on. But by the time I came, it was really stigmatized, and I was totally stigmatized by health workers. Said, why have you brought this disease into our country? You are, you're sick, you are promiscuous, you are everything. I went through all that. And I think what we need is sometimes lack of knowledge. because, you know, people at that time didn't know much about what HIV is. And I think we need to do a lot of community sensitization and treatment literacy. And treatment literacy, people think it is only for us living with HIV who need to know about the basic facts of HIV, what HIV is. They think it should be only us. Now we've discovered that health workers need a lot of training on this, on disease, how to handle people living with HIV. So information sharing, training people how to handle, how to live with people living with HIV, sensitizing people in the community that don't stigmatize the people. This can be your own child, this can be your own sister. We need a lot of community sensitization. There will be stigma and there is stigma. We can't say there's no stigma. But I think talking to people and giving our stories and giving the face of the epidemic reduce the stigma in this country, in our country, Uganda. If people had not come out and talked about it, people like Major Baramira, who came out many years ago, people like Mili Katana, people like Beatrice Were, those people came out long ago and gave the face of the pandemic. So speaking about it, giving our testimonies, telling people, here we are still living after more than 20 years, living with the virus. All this reduces stigma, but also telling, talking, giving more information to people. Some people up to today don't know that you can shake hands with a person living with HIV. It's surprising after more than 30 years of that virus here. You can share a cup of tea with a person living with HIV. We need to start with our own families and then talking to other people in the community about it, training and sensitizing. We do that all the time. We try very hard to fight stigma by going around telling people, stop using these, and using particular language. We've talked about language. We've talked to people about language, the language you use, people living with HIV. Those were days they used to call us victims. And the word victim is self-stigmatizing. They call you are living with AIDS, and we're not living with AIDS, we're just living with the virus. And I think TASO did a lot of work. We as networks of people living with HIV should do it ourselves. Go out there and talk and correct people in a gentle way, because a lot of it comes from being uninformed, not knowing about this, the disease, not knowing how the virus is spread. They think if I shake hands, if I come close, if I hug a person, I may give them that. And then, of course, treatment has helped because we are now living normal lives. So they see us as if, oh, she just has HIV, but she's normal. You know, these things have helped. And treatment literacy and making sure everybody gets treatment. That's another one. Thank you.
Thank you very much. And another question that came in is focused on caregivers. At Purposeful Aging, we have two audiences, like mentioned earlier, the elders themselves, as well as people who are caring for the elderly. So this question is about what tips you could give to caregivers of people who are elderly people who are living with HIV to help them, one, be able to identify symptoms that may warrant taking the patient to a clinic, for example, if this person is not able to take themselves, or symptoms that they need to point out to the doctor, and then also things to encourage for caregivers to look out or better manage the psychosocial issues, mental issues really that arise in elderly people who are living with HIV.
Well, to begin with, I think every person who's living with HIV needs a health center that they are attached to. Whether it's very far away, they need to be attached to a health center where they can easily go if they develop any symptoms of any kind. But just like any other elderly person who is in their home, they need caregivers. And the caregiver needs to be aware that the treatment is taken at this time, every day, that but if there are any changes in the body or in the life, in the health of a person, immediately must contact a health worker. And I think people need to be supported in that way. Nutrition, make sure that they eat the right foods, and they are eating foods. These drugs cannot be taken without food. And of course, as I had mentioned earlier in my talking, making sure that these people are active in their lives. But of course, now I had talked about non-communicable diseases, because these are the ones which are really affecting elderly people. And having non-communicable diseases which most elderly people have, even if they don't have the HIV virus. We need to be able to have a health center. And then, of course, the issue of counselors, we have a problem because there are not many counselors in the health center. It's not a position in the Ministry of Health at all, but there are what we've got, the VHTs, and some VHTs are good counselors, but also family. And I think every elderly person has to have a treatment supporter. You must have somebody who's around the person, and a person who cares for them. Many times we think they care for themselves. They can't. If they get very sick, they need somebody around them. So, and they must live within their families, not in isolation. One of the things that really affects elderly people is living in isolation, and mental health comes in at that time. That's it. And I think also, of course, caregivers need to know a little bit about the medication, what kind of side effects somebody can have. I really believe that sensitizing caregivers is one of the most important things that we have to deal with. How do we sensitize caregivers? We should include them when we are training and when we are sensitizing in the community. Sensitize caregivers so they come and they learn to know about these medicines that they must be taken, the kind of food that the person must have, the kind of care the person must have, hygiene, and all those other things. And also, the other thing is also the person themselves. Sometimes we're talking to family and we're not talking to the person themselves. I think we need to do self-training, teach a person themselves how they must live their lifestyle, not to live a lifestyle where you're going to forget your medication, to live a lifestyle of coping with the treatment, coping with the illness, coping with stigma, self-stigma. Because sometimes it is self-stigma. It may not be other people stigmatizing, but it's you yourself. You feel, oh, if they see me, if they know I'm taking treatment, this is how I am. So training people themselves, training caregivers all the time on side effects of the treatment, on how they must care, if they can recognize that somebody is changing, health is changing, immediately be able to get them to health facility. And now we have the differentiated care models where people have, the Ministry of Health has come up with these, what we call the CLAD groups, where somebody does not have to go all the time to collect treatment, but a group collects together of 6-7 people, and they send for the treatment every month. And these are differentiated care models for reducing transport costs. If people live very far away from the health center, you can go and pick, and the medicine can be picked by one leader who goes and brings treatment for the group, as long as the person is not having any other. And the other thing is, of course, making sure that people go for their blood tests, at least a viral load when the hospital says it's time for you to come and take your blood test to make sure the viral load has gone down. And if your viral load becomes undetectable. Actually, somebody asked that. I think I missed that. What's your viral load now from having a CD4 count of 1? Now we don't use so much the CD4 test. We use the viral load. So in that way, we get to know that, my viral load right now has been undetectable for many years. So that's how we test. CD4 comes in, of course, if the doctor sees that you need a CD4 count. Right now, we're checking our viral loads. And of course, if somebody, for the younger people, not us, who want to get pregnant, want to give birth to children, make sure that they are going to the health facility and the doctor will tell them what to do.
Okay, thank you very much for that comprehensive tip. I have a few more questions as we wind up. These ones are really easy. We've had someone asking about the WhatsApp, if there is a WhatsApp group for women at 40. I think they'd like to join and be part of the group. Someone has also asked for your contact, if it's okay for you to share that. They'd be happy to, I think, get in touch with you. And also a question about meeting places for people. Someone mentioned loneliness and the need for us to go back to that meeting for people to be encouraged and draw strength from one another. So if you know of any places where elderly people living with HIV can meet, also that would be welcome. You could answer those before we ask Dr. Isaac Lwanga to speak.
Okay, I really want to start with elderly people because really I do not know even up to now where elderly people living with HIV can meet. We are the very people, and we are meeting in meetings, we are meeting in forums where we meet, but there are people who are even older than me, and and they need where to meet, and that's what I'm saying, that this is what we must work on. With as Prosi had mentioned to you in Tororo, where she said, where is that place where I can go and meet and hug my person? We actually meet in fora like meetings. Women at 40, we are trying to create a system where we can actually have, well, there's a time when we used to have what we call champions of good hope, and champions would meet in somebody's home at least regularly and say, this is where everybody, it wasn't only for elderly, it was just for people living with HIV. We have a big umbrella body called the National Forum of People Living with HIV, which brings us together. And there are networks in every single district. And those district networks is where people get together in the districts. And I think really this is one of the things that we need to work on and decentralize, and not say only in Kampala in the boardroom, but where we can meet. Of course, there are at treatment sites. We had formed what we had called family support groups for. Now, this was mostly for the women, for the mothers. When we had started the mother networks, the Ministry of Health also formed what they call psychosocial groups called the family support group. And this is a challenge. And I can see when Prosi asking this question, not everybody has a mobile phone. So where do they meet? So those treatment centers, post-test clubs that used to exist when TASO was going out, and other organizations are forming these post-test clubs where people go for treatment and meet at treatment centers. They sit outside afterwards and they discuss. In some districts it's happening, but not everywhere. And this is a hard work, as I'm telling you. Our work has not ended. Each day I wake up, I feel I'm just starting. What do I do next? What can I do? What can I contribute? What ideas can I bring? Where can I, give people that sense of coping that I have not done in my life? And this is one of the things that we are trying every single day. Yes. Somebody's offering space. I see Dr. Shaban.
Yes.
Dr. Shaban, by the way, is Ministry of Health, but he's working at the Uganda AIDS Commission. I've just seen he's offering a space.
Yes,
But
I
now,
see that as well.
yeah. But I think I cannot really answer Prosi that way, because she's saying that in the rural communities, this has died out. And I think we have got a big job to do. Prosi, you are part of the work, doing the work with me, you and me and many others. Let's work hard to make sure that we find this. Thank you.
Dr. Lydia, your contact, maybe you could share it in the chat while Dr.
My telephone
Lwanga.
number, my telephone numbers as my cell phone number is 075 999 5233, and that is my WhatsApp number.
Okay, that's
075 999 5233. My other number is 0772 448 102.
Okay, thank you. We have a hand up. Dr. Isaac Lwanga, you'll be our last speaker. We're getting to the end of our time. Please unmute and
excuse me, I want to ask, is this recorded? Have we
yes,
recorded
yes, the
this
session
Zoom?
is recorded, and we can send you a recording via email, preferably.
Thank you.
You can put it down in your chat, and we'll be able to pick it up to send you the recording.
Okay, I think Dr. Christine has my email address.
Yes, yes, we do. Mhm. Okay, Dr. Lwanga.
Hello. Hello. Thank you very much for organizing this session. I'm Dr. Isaac Lwanga. In fact, I worked at TASO before I moved to other engagements. I'm very passionate about HIV and aging, and where I worked until recently, I did some good work in this area in terms of setting up a special clinic for the elderly patients. And I also did some kind of study about the physical functionalities in these elderly HIV-infected individuals. As we know, HIV accelerates the aging, but more so affects the physical functionality. And when this happens, it even takes away that independence from these elderly people. So I just wanted to inform Lydia that at an opportune time, we shall link up and see how we can put in that aspect in your efforts, because this is something which can be done in the communities, and then it adds a lot of difference in terms of the quality of life of these elderly senior HIV-infected individuals. But otherwise, thank you very much for continuing the fight and organizing this session. Thank you very much.
Thank you so much, Dr. Ranga. Dr. Ranga was with me as we began that when I began as a medical officer. I used to sit with Dr. Ranga in TASO many years ago. He's lost to me now, and he's now appeared again. So I'll make sure I get in touch. Thank you so much.
Great. I'm going to hand back to the moderator at this point. And thank you to all who have put emails or contact details in the chat. There's also a link for you to register in the chat as well. Martha has just posted that so that we can keep in touch with you for future sessions as well as a recording for this session. Back to you, moderator.
Thank you very much, Dr. Philippa. Everybody online, could you join me in giving Dr. Lydia a huge, huge clap for this session? It's been wonderful. Can we give her a clap, please? Use your reaction.
Our virtual clap.
Dr. Amri.
Yes.
Yeah.
And as we go ahead with the clapping, I would like to give a short notice for our next session. It's supposed to be at the last month of March. And as you all know, it's going to be Easter time, around that time. So we will not be able to get an online session, but would like to encourage each one of you to be active where you are, to be exercising, and probably take a video of your exercise group or discussion group. Now we also want to load on discussions for people living with AIDS, with HIV. I'm sorry about this. I'm so sorry about this. People living with HIV, our caregivers, and us, the older adults, please, let's get together, record a small meeting, which you do on that Saturday, and share it with a Purposeful Aging group. Dr. Lydia, this has been a very, very, very touching session. Apparently, AIDS is more social than many of us have ever thought of. There are many areas which we have not managed to cover this morning, but we are very grateful for the sharing and the sharing of deep, deep personal circumstances you've gone through. And for all of you who have contributed, thank you so much for sharing. Thank you so much for really putting, the dots on those I's which we have taken for granted. And yet, as we grow old, they are catching up with us. We are here, we are living with HIV, and we are going to fight the battle like Lydia has done and continue fighting till the end. Thank you so much. I will see you in May, but we're always open for questions and suggestions. We'll see you in April, sorry. April. Thank you, Dr. Philippa. We'll see you in end of April with another session. Thank you so much. And
thank you so much, everybody. Thank you.
Thank you, Lydia.
Thank you. Have a